will start roll call. Chair Delgado?
Here.
Vice Chair Lucy?
Here.
Michael Brown?
Here.
Councilman Dare?
Here.
Dr. Dinko?
She's trying to get on.
Okay, we'll come back to her. I'll watch for her sign on. Dr. Novak?
Here.
And Dr. Clacking? I know I heard him earlier.
I see him,
But-
he's on mute.
Yeah, Chair, we have a quorum.
Okay. Thank you. Dr. Novak, can you please lead us?
I'm
in the
here.
pledge?
Place the flag. I pledge allegiance.
Thank you. Moving on to item number 3, approval of the agenda. Can I have a motion, please?
I move. Brown moves.
A motion is
Second.
second. All in favor?
Aye.
Opposed? Motion carries. Closing item 3. Moving on to item 4, recognitions.
Chair, before we move forward, can we make it a brief announcement, please?
Yes, please.
So all public comment is limited to 3 minutes per person and should be addressed to the Board of Health as a whole, not an individual. With the exception of the public comment agenda items, comments will be heard for items labeled for possible action and should be specific to the item being considered by the board. District Board of Health conducts the business of the Washoe County and its citizens during its meetings. The presiding officer may order the removal of any person whose statement or other conduct disrupts the orderly, efficient, or safe conduct of the meeting. Warnings against disruptive comments or behavior may or may not be given prior to removal. The viewpoint of a speaker will not be restricted, but reasonable restrictions may be imposed upon the time, place, and manner of speech. Irrelevant and unduly repetitious statements and personal attacks which antagonize or incite others are examples of speech that may be reasonably limited.
Thank you, Susie. Appreciate that. We'll go on to, these are recognitions. We're not taking an action on these items. So, and then after this, we'll do public comment. District Health Officer.
Yes, thank you, Chair Delgado. I'd like to begin with years of service. Want to recognize Rebecca Gonzalez. I believe she's, yes, she's on there. She is waving. Rebecca is being recognized for 20 years of service with the Health District as a public health nurse in CCHS. So congratulations, Becky, and thank you for all your service for our community. Also wanted to recognize Kristen Palmer. Kristen's our fiscal compliance officer in the Health District, and she has 20 years of service with Washoe County, and she actually most recently joined us during our COVID-19 response. So congratulations to Kristen. Thank you for your years of service. Nicole Alberti has 15 years of service with the Health District. She's a health education coordinator with CCHS. So thank you, Nicole, and congratulations for your service. Byron Collins, environmental health specialist, being recognized for 15 years of service as well with the Health District. So thank you, Byron. I think he's hard at work out in the field. And we also are recognizing Mike White, office support specialist in EHS, with 5 years of service here at the Health District. So congratulations to all of them, and we'll have certificates and service pins for them for their recognition. I have also some new hires I want to recognize, and I'm going to go out of order on these because I think Susie has got some pictures set up for us, so you can get to know them. I'd like to begin with Bailey Tabor. We've got 2 environmental health specialist trainees, Bailey and Jessica Gerhardt. Bailey has an education in nutrition and environmental science. She has a diverse background in food service, food science, clinical nutrition, sustainable agriculture, and environmental safety regulations. She's originally from this region and has lived also in multiple other places in the Western U.S. She recently welcomed a new baby to her family, and she's excited to be part of the Washoe County Health District team. So welcome to Bailey. And Jessica comes from an environmental background of drinking water and stormwater, and is always dreamed of serving a role focused on protecting humans' health, safety, and the environment. When she's not working, she's taking hikes with her 2 dogs, mountain biking, rock climbing, meditating, reading books, and spending time with loved ones. So welcome to Jessica. We have also a couple of employees, new employees with CCHS, Ashley Humes and Amanda Santos. Ashley started working in the sexual health program as a public service intern back in July of 2018, while she was working on her bachelor's degree in community health sciences in public health. After she graduated in this past August of 2021, she transitioned to be a contact tracer for the CDC Foundation, where she continued to work with the Washoe County Health District Sexual Health Program. The CDC Foundation has been supporting us with several of those positions. In this position, she was not only responsible for contact tracing, she also took on a caseload to include chlamydia and gonorrhea cases. Her dedication to the program, teamwork, and willingness to learn make her an ideal person to join our team. So we're excited to have her here now full time. So congratulations to Ashley on her new position, and welcome. And Amanda Santos, she is working with the Chronic Disease and Injury Prevention Program. She's the team's newest health educator. Amanda will be focusing on physical activity and nutrition efforts, and she brings significant experience and skills to the team. She has a master's in public health from UNR and experience working in a variety of programs at the Nevada Department of Health and Human Services, including work with community health workers, breast and cervical cancer early detection, cancer control, diabetes, and HIV surveillance. She's committed to improving the health and well-being of our community and in her new role at the Health District, and we're thrilled to have her joining our team as well. So congratulations to all of our new hires. Also have a couple of promotions I wanted to recognize. Rayana Lavoie, these are actually both with the Office of the District Health Officer. Rayana Lavoie has been promoted from a health educator 2 to a management analyst. That was effective this past December. And our very own Susie Valdespin has been promoted from an administrative secretary to an administrative assistant 1, also in December. So congratulations to Rayana and to Susie. And then we have several retirements. Kim Franchi has retired from EHS, where she served as an environmental health specialist for 15 years. So congratulations to Kim on her retirement. That was effective December 21st. Jeff Brazel also has recently retired from EHS as an environmental health specialist, senior environmental health specialist, excuse me. While he's I think using up the last of his vacation time. His retirement is effective at the end of the month on the 31st. And Isabel Chavez, I see she has joined us. So congratulations, Isabel, on your retirement with 26 years of service to the Health District as a community health aide in CCHS. So thanks for joining us and congratulations. And we do have a token of our appreciation that we'll provide for you. And then wanted to also recognize some special recognitions. First, I'd like to recognize Diana Karlasek. She has stepped up once again as our organizer for the Health District's Adopt a Family campaign over the holidays. So she has done this for us a number of years in a row, takes this on herself and recruits the support from the Health District. With her efforts, we helped 3 families, a total of 14 people. We had 36 people at the Health District that donated cash or gifts. We collected 17 hygiene items for all of the families, 50 cleaning items for all of the families, 151 items were wrapped to put under the families' trees. They received each a $100 gift card to Winco, and we generated $1,425 in cash donations. So I call Diana our holiday angel at the health district. I really appreciate her efforts to organize this for families and the health district support each holiday season. So congratulations to Diana on her efforts there. I had the honor of being awarded the Administrator of the Year by the Human Services Network. And Julia Ratty was honored with receiving the Michael Callahan Humanitarian Award. Let me say that again. Michael Callahan Humanitarian Award from Human Services. This is a really significant award. It's often viewed as a Lifetime Achievement Award and I believe it was presented with her stepping down from her Senate seat. I was thankful that everybody acknowledged that Ms. Ratty's work is not over. So those are the recognitions that I have. Thank you very much, Chair Delgado.
Thank you, District Health Officer. Congratulations to everyone that was recognized today. Thank you for all your hard work, and welcome to all the new employees to the team. Any comments from the district board? See none, we'll close item 4.
We'll just say welcome, everybody. We're glad you're here. Thank you all for all the work you've done. It's been an incredible couple years, and that's from all of us to you. You're awesome. There you go. Is that good?
Thank you. Good job, Councilman. Closing item number 4, move on to item 5, public comment. Susie.
Yes, Chair Delgado, and I also wanted to place on the record that Dr. Dinko logged in at about 1:10 p.m., so she is present.
Perfect, thank you.
And we'd like to call Mr. Nicholas St. John, if he can unmute himself, please.
Okay. I have a number of items I'd like to have addressed. First, while we appreciate the recognition of the people who work there, we're still not satisfied with the work that Health Officer Kevin Dick has done, and we still demand that you remove him or fire him. My first item is that we, the people, demand that all so-called COVID-19 vaccinations for those ages 5 to 20 be immediately terminated, as the CDC's own data indicates this age group is not a threat of spreading COVID, and that the chance of death is less than 1/5 that of measles, and can be lowered to virtually 0 if proven therapeutics would be promoted and used during early detection. Speaking of therapeutics, we the people demand that therapeutics be promoted and used to treat all COVID patients that enter a hospital. These therapeutics include ivermectin, hydroxychloroquine, budesonide corticosteroid inhalers, 0.3% food-grade hydrogen peroxide nebulizers, 0.6% chlorine dioxide solution nebulizing, chlorine dioxide solution, which has completely eradicated COVID from Ecuador, Bolivia, and Colombia, plus a regimen of supplements such as NAC 600 to help keep respiratory illnesses from becoming pneumonia, zinc, quercetin, vitamin D3 with K2, minimum 6,000 milligram vitamin C or 25,000 milligram vitamin C IVs, which I was denied at the emergency room of the VA, and and then also monoclonal antibody infusions, which I now understand the FDA has terminated its use. These need to be made available to and explained to all COVID patients as options for treatments. We demand the termination of the use of remdesivir, which had a 53% fatality rate in previous clinical control studies. 53%, guys. That's what they're telling them to use on people. Patients' rights must be restored. If a patient asks for any of these treatments, they must not be denied them. My third point, we the people demand that this board provide 3 studies completed prior to January 2020 showing that masks can prevent airborne respiratory illnesses. You have 5 days to provide these studies if you can find them. If you cannot provide scientific evidence prior to this COVID pandemic, we demand that you cease and desist in all suggestions or mandatory mask requirements for children and adults alike. The governor cannot make law. Mask mandates are not law. They are based loosely on the CDC emergency use authorized mask use guidelines, which by law cannot be forced on any person without their informed consent as a medical device. And no one except a person's private physician can advise such use, which can be refused and not complied with without any retribution.
Okay, Chair, we have 3 additional comments that were registered, but we have Cindy Martinez, if she could unmute herself, please.
Good afternoon. Thank you. For the record, Cindy Martinez, speaking in my capacity as a private citizen, and I concur with and support the statements of Nicholas St. John. Today is day 686 of the state of emergency declared by Governor Steve Sisolak. As we look around our state, our country, and the world, it is clearly apparent the false narrative created around the quote pandemic is falling apart at greater speed every day. Health restrictions are being lifted around the world. Florida's case rates are falling at a rapid pace. Some countries are declaring the coronavirus infection to be endemic and on par with the seasonal flu. The fraudulent testing process is driving a quote case rate that is not based on true infection rates. This county health board is complicit in the mismanagement and government corruption of the response to COVID-19. People infected by SARS-CoV-2 virus who presented with early symptoms were sent home, told to isolate, and only returned to the ER as symptoms worsened. They were denied efficacious early treatment based on protocols established by now censored and silenced medical professionals. They were forced to submit to protocols established by the CDC and the pharmaceutical cartel. On October 28, 21, Health Officer Kevin Dick asserted the county had, quote, community in its freezers, end quote. On December 7, 2021, I submitted a public records request for proof. On December 15, 2021, I received documentation of Pfizer product ordered on September 8th, 21, and shipped received in October of 2021. I submitted this information to a molecular biologist by training and education who stated, based upon this documentation, Washoe County Health District does not have Comirnaty in its freezers. I spoke with a trauma surgeon who confirmed Comirnaty is not yet available in the United States. I called a local pharmacy, which didn't know what I was talking about. If it was available, the EUA for the Pfizer COVID-19 injection would have been lifted. It has not been lifted. The county continues to administer emergency use authorization experimental gene therapy injections to a largely unsuspecting populace. This is immoral, unethical, and I dare say criminal. I thank the Board of County Commissioners for lifting the county emergency declaration on December 14th, 2021. I respectfully call on Vice Chair Bob Lucy as member of the County Commission to intervene in this horrific medical debacle and stop the administration of these experimental medications. There is no emergency, end the emergency. And Kevin Dick is an air quality management expert. He is not an epidemiologist, an immunologist. He's not a virologist. He has no medical training. And Administrator of the Year means he's a very good paper pusher. He is guiding health policy, and he has done a poor job of it. I demand that he be fired and replaced.
Up next, we have Mr. Peter Kruger.
Board Chair and members of the Washoe County District Board of Health. I'm Peter Kruger, State Exec of the Nevada Petroleum Marketers Convenience Store Association, which is a statewide trade association representing petroleum wholesalers, retailers, and convenience stores owners. Last month when we came before you, we were not necessarily in opposition to the new UST tax, but did want to address concerns industry members have with the new tax. Members understand that your UST program can't operate at a loss, but going from $0 to $875 per permittee in 6 months will be definitely a hardship in some of our smaller members. It appears to us that the figure, the $875 tax, was arrived at by simply dividing the number of permit holders into the budget shortfall. Members are also concerned about, and this is a significant concern on our part, the idea about one size fits all permit holders. By that, I mean, how does it take 6 hours to inspect an emergency generator site with one tank and no dispensers, and the same 6 hours to inspect a big box station which has more than 10 dispensers? Lastly, we truly believe that your hearing process is unfair in the sense that the staff gets unlimited time to present their proposal, why trade groups such as ours and others get only 3 to 5 minutes, depending on the board decision. And in doing that in 2.5 minutes, thank you.
Up next, we have Ms. Val White. If you could unmute yourself, please. It looks like she might have disconnected, Chair.
Okay,
Excuse me, I thought I was unmuted. May I continue?
Yes.
Yes, please.
Regarding Administrator of the Year award to Kevin Dick, it's just a travesty. It would be a joke if it weren't so harmful. He needs to be fired. He's no expert in this field and should not be issuing any kind of recommendations to anyone outside of his house. Second, Commissioner Lucy and Councilman Delgado need to resign if they really care about this community. They've both done more things than I can mention in the time allotted that evidence the harm you've done to the community. That again is another travesty. And I don't know how your consciences allow it, but if you're deceiving yourself into believing that you're helping the community, you're wrong. Next, the COVID mandates and recommendations need to be removed entirely. Exactly how does this board maintain any sense of credibility or earn the community's trust in the face of the several countries that are now ending all mandates and coercions? How does this board be so far behind the real science, not the fake data that's coming down to you from the CDC? How do you balance that? How can you even think about that with any reason and come to the conclusions you're coming to? What are you going to do when all the information is fully released that this vaccination for COVID, these mandates were nothing but criminal activity, all the way up to murder? You guys have blood on your hands for the mandates and the recommendations you've done. It's the epitome of ignorance or corruption to have issued the COVID mandates and recommendations that you've made to date based on the fake and faulty data coming from the CDC and Big Pharma. I look forward to Nuremberg Trials 2.0, when all of you who have done this harm will have to face the consequences. Thank you.
Thank
We
you.
have no more public comment, Chair.
All right. Thank you, Susie. We'll close item 5, public comment. We'll move on to item 6, COVID-19 update and information. District Health Officer.
Yes, thank you, Chair Delgado. Let me begin by stating that the Health District and the District Board of Health don't have any mandates regarding vaccinations or mask wearing. Also, the District Board of Health and the Health District don't have any role in oversight, regulation of treatments for COVID-19. The Pfizer BioNTech COVID-19 vaccine that was fully authorized by the FDA for use in 16 and olders. When it was authorized, Pfizer hadn't even proposed the use of the name Comirnaty at that point. So the authorized vaccine is also known as Comirnaty. It's the same stuff. And that vaccine retains its EUA because it's the same vaccine that's used for vaccination of 12 to 15-year-olds. And those vaccinations are provided under the EUA and not under the full authorization that was provided for that same vaccine in individuals 16 and older. As far as our current situation, we have nearly 100% of all cases now occurring in Washoe County are the Omicron variant. Our 7-day average of new cases in Washoe County are over double our previous record of new cases that we set in November of 2020. We're at about 210% of that record now. Our 7-day average is at 1,028.7 new cases per day. Our new cases currently seem to be leveling out at about this rate. And we're hopeful that this is a sign that we are at about the peak of the surge, but we'll need to continue to monitor to see if this is the case. The levels of COVID-19, as I mentioned, are still incredibly high. Omicron is incredibly transmissive. So if we are reaching the peak, that doesn't mean we can let down our guard. Our cases need to drop very, very significantly before we're out of the woods. We have many more cases that are being reported, or that we have many more cases than are being reported in the numbers that I just reviewed for you, because those don't include at-home tests. We also know that our 7-day average for test positivity is at 42.89%, almost 43%. So we know that our testing is not fully meeting the demand for testing that's out there. All of the test results aren't being reported to us. So based on what we've seen in other communities, as far as where they hit with the Omicron peak compared to what they saw with their 2021 winter peak, we expect that we have probably 2 to 3 times that many cases that are out in our community of what we're reporting. Our new cases over 7 days per 100,000 population is at 1,626.7 under the CDC's reporting framework, and the CDC thresholds for high transmission, to remind you, are at 10% positivity and 100 new cases over 7 days per 100,000. So we're fantastically beyond those thresholds. Masks continue to be required indoors in public places under the state's mask mandate. Our hospitalizations have been increasing, and the Nevada Hospital Association reported a 7-day moving average of about 214 people that were reported hospitalized for COVID-19 in Washoe County. That was reported on Tuesday, the 25th of January. That's more than a 4-fold increase over hospitalizations reported in early December, and double hospitalizations just a couple of weeks ago. We expect those hospitalizations to increase over the next several weeks after we do reach the peak of the surge, because those are just lagging after people do become sick and then become more severely ill. The Health District requested the National Guard support to increase our testing capacity at the Reno Parks Livestock Event Center. Those Guard have been deployed, and they joined us on Tuesday. We are beginning full-day testing operations, and that's beginning today. And that will operate now Monday through Saturdays at the post. We're able to expand our testing capacity to about 800 on weekdays and about 700 on Saturdays. Our staffing, our key pinch point for staffing is testers. The Guard was only able to provide us with 1 additional medic so far, so we're appealing to our volunteers and staff to step up for filling those positions. But we are working with the state and FEMA to further bolster our testing with a FEMA unit, and we're hopeful they'll be able to join us next week, and we'll be putting out further information on that as it's available. Public can schedule to be tested through the COVID19washoe.com website, or by calling our 328-2427 number. Also, free home test kits are available from the federal government. It's an easy process for people to get those by going to covidtests.gov. Vaccinations remain our best protection from COVID-19, and they've been demonstrated to be incredibly effective in preventing hospitalization and death from Omicron cases. Most of the breakthrough cases that do occur in vaccinated individuals are mild. People that are looking for a booster shot or to initiate their vaccinations can visit vaccines.gov or go to our covid19.washo.com website to be able to be scheduled for vaccinations of the booster. The vast majority of our pharmacies are administering vaccines, and we're also offering vaccines each weekday through our clinic. Those can be scheduled by calling 328-2427, and we're continuing with our community pods. The vaccines that have been administered through the county-wide, have declined since December. Before the holidays, we were seeing over 14,000 vaccinations administered per week. And we've seen, although we've seen a slight increase in the past week, that brought us to about 10,500 vaccinations administered countywide. So we have seen a decline from the initial rush. I think that was largely driven when Omicron was first announced. But of the vaccines that are going out now, about 80% of those are boosters that people are returning for. Because of the high number of cases that we're having reported daily, we're using text messages to connect with people that test positive and to alert close contact cases. The texts that we send to the positive cases have a link for people to go to our website and complete a survey, which is what would have been the disease investigation that would happen with somebody calling them. So this is helping to automate our process. And it also then allows us to automate the notification of those close contacts through texts. There are several treatments available to treat individuals to prevent hospitalization or death from COVID-19. I want to highlight a couple of these. While they're in very limited supply, we are receiving these in our community, and we're expecting for the production to increase and for more of this to be available in the future. The treatments include sotrovimab, and this is a IV administered monoclonal antibody. And this is because of the limited supply, the priority are for people that are immune compromised, have other underlying health conditions, and are elderly that make them very high risk for severe disease. And we also have two antiviral pills, the Paxlovid, that's the Pfizer product, and Molnupiravir, which is the Merck product. The supply is limited on both of these. The Paxlovid is available through our hospitals and through CHA, Community Health Alliance. This one as well is specifically prioritized for those most at risk of developing severe COVID-19, immunocompromised, elderly with those underlying health conditions. The Molnupiravir is the Merck product, and it's also being distributed to several of our pharmacies in the community. But again, we hope these to be more widely available in the future. And with that, I'll turn it over to Dr. Danko if she has some further comments she wants to make.
Hi, thanks so much. I don't know if you can hear me. I'm having some microphone issues maybe.
We can hear you just fine.
You can hear me, perfect, okay. Thanks for having me. That I think was a really nice comprehensive update. From a hospital perspective, I think, I often hear that this newest surge of COVID is less severe, but that is of course not true for us in the hospital. We still see, significant disease, and I will highlight that very predominantly, if almost not exclusively, the hospitalized patients are unvaccinated. We very seldom come across a patient who is fully vaccinated, who is struggling with COVID-19 disease that requires hospitalization. We do still see a capacity burden on the hospitals, and this is contributed to by the COVID infections. And we're still seeing patients with COVID-19 who require ventilation and life support. And those patients are still having very, very high severity of illness, and oftentimes significant outcomes with death and not getting better. The ones that do get better, still we see the length of the hospitalization be very significant, upwards of many days to even many weeks. We still are seeing lots of the same trends in medications, and very much to highlight what Mr. Dick said as well. We have a supply and demand issue with some of our outpatient medications, such as the new antiviral medications. And those are mainly for patients who, again, are at risk for progression to severe illness or at high risk for severe illness. In the hospital, we're still predominantly using corticosteroids, as well as remdesivir and occasionally interleukin-6 antagonists that we have available. But again, sometimes that also has a supply and demand problem even within the hospital. So that's mainly what we see, is that we're still for sure seeing severe illness, and certainly predominantly in unvaccinated individuals.
Thank you, Dr. Danko. Any questions from the board for either District Health Officer Kevin Dick or Dr. Danko? Yes, Vice Chairman.
Thank you, Chairman. Dr. Danko, outside of the patient load that is impacting the hospitals, are we seeing staffing issues at all of our four regional facilities that are also being impacted in not only our emergency rooms, but in the ICUs?
Yes, absolutely. That's a really great question, and thanks for bringing that up. We for sure are seeing staffing issues in the hospitals, as well as in our post-hospital care facilities, such as long-term acute care hospitals and our skilled nursing facilities and acute rehabs as well. And right now at some of our post-acute facilities, we're doing something like daily testing to make sure that someone who's asymptomatic isn't coming in with an active COVID infection. And actually, we're coming across many people who do have COVID that are then not able to work clinically, even though they've shown up for that work that day. So we're definitely having limitations and capacity issues also from staffing, absolutely. And I think that brings a good segue into, even with our new medications like antivirals that we have available and things like that for those at high risk, still our best opportunity is prevention, really, to try to prevent COVID infections so that we can have more people that can staff these facilities and thus help our ability to take care of patients at all levels of care, not just in the hospital.
Thank you, Dr. Danko. And it's my understanding as well, with the skilled nursing facilities and the acute rehabilitation, that there are certain, because those facilities are privatized and outside of the realm of guidance from the localities, but those are fall under state guidance, do they not?
They do follow under state guidance, but we still follow the FDA recommendations and CDC recommendations to do the best we can in those facilities as well.
Right. I guess my point is that from my challenge, my discussions from some of the rural hospitals, that they're having challenges transporting to our facilities for maybe some more acute care because of our bed space being occupied by individuals that are waiting for bed space within our skilled nursing facilities, and also the acute rehabilitation as well. And so I don't know the details, all the nuances of that, but from what I've heard from individuals in Banner Health and some of the outlying hospitals, they've been having difficulties transferring patients in due to bed shortages and staffing shortages within the EDs and also the ICUs, because of not being able to discharge individuals out to acute care and also skilled nursing facilities. Is that correct?
That makes a lot of sense. Yes, we're seeing that at our level too, is that there's sometimes a backflow because, for example, if there's a facility that's in active outbreak status, then oftentimes just to be able to control that, or as you mentioned, because of staffing issues and not having bed availability because of staffing, then those facilities can't accept. And you're exactly right. Then there becomes a backflow on the beds that are available within ER or within the acute care hospital as well. Absolutely.
Okay, thank you. Thank you, Chairman.
Thank you, Vice Chair. Any further questions from the board for Dr. Danko or District Health Officer? See none, we'll close item number 6. Moving on to item number 7, consent items. Anybody from the board like to pull the items? Yeah, yes, Susie. Okay. Thank you. Anybody like to pull items from the consent agenda? See none. Any public comment against is related to consent? Okay, can I have a motion, please, on consent items?
To approve, Chairman.
A motion
Second by Brown.
and a second. Further discussion? See none. All in favor?
Aye.
Aye.
Any opposed? Motion carries. Moving on to item 8A, review and acceptance of the Remsa Health Operations Report. Mr. Dean Dow.
Good afternoon, Chairman of the Board. For the record, Dean Dow, President and CEO of Remsa Health and CareFlight. Should have before you for your review our monthly summary, and happy to ask or answer any questions you may have at this time.
Looking to the board, any questions for Mr. Dow? Item 8A. See none. Mr. Dow, I have a question or two. And how's the assessment referral protocol going?
Mr. Chairman, actually, I can let Aaron Abbott and Adam Hines from operations answer that question. It would be all right with you, but globally, we've taken a look at it this week, or I did this week with them. It's actually in utilization. The interactions with patients so far have been actually spectacular. The patients have been very, very appreciative of having the opportunity to look at, if you will, options, and us assisting them in obtaining or getting to those options. So if it's all right with you, I'd turn it over to my ops folks to maybe put a little bit more color to it.
Sure, thank you.
Thank you. Aaron and Adam, if you want to comment.
Sorry about that. Trying to work on my video here. Yeah, so Aaron Abbott, Executive Director of Operations for Remsa. It's been in effect for a couple of weeks now. We have done some messaging as far as community messaging regarding the Assess and Refer program. And so far, as Dean has articulated, the patients have received it quite well. I don't have some numbers for you in front of me, but we're doing a couple a day. So they're not huge numbers, but any one patient that we don't necessarily transport to the emergency department is resources saved. And those patients, as we've said, have been extremely receptive to the process. So we look forward to collecting a little bit more data, continuing to monitor the program, and then hopefully being able to continue to report success back to this board.
Thank you, Mr. Abbott. So would I be looking at you guys providing total numbers of assessment referred patients maybe on the coming reports?
We can absolutely do that.
Absolutely. Chair Delgado will be happy to, in the February meeting, present you with a PowerPoint presentation of some of the numbers and some of the outcomes, because we'll have obviously a deeper database to go on by that point.
Thank you. In line with that too, the total number of ILS response and transports, I didn't see that in the report unless I missed it.
It is not in there. And again, we'll let Aaron and Adam speak to
that. Yeah, Mr. Chair, we're doing about 30 ILS responses a day in the 911 system. The repatriation rate into an ALS provider is extremely low, and those are usually centered around things like pain management and not criticality, and aren't changing or resulting in any patient outcome changes. So about 30 of those a day. And although by the numbers, 30 out of 200 isn't, responses a day isn't the majority by any means, but those are 30 ALS resources that we had available to respond to higher acuity patient complaints per day. So that's, as far as we're concerned, definitely a success. We're hoping to get to the point where we're doing, 200 to 300 per month would be successful for us. So we can definitely report those along with the assess and refer numbers on a more concrete basis for you next month.
Thank you.
Adam, do you have anything to add to?
Yes. Thank you, Mr. Chairman. Adam Hines, Executive Director for Remsa Health. We do have those prepared in a staff report, specifically the ILS responses, and then a verbal report for EMS advisory, which is next week. My intention was to socialize and circulate it there and then have that percolate up through the District Board of Health, and then begin in February to kind of jump in and begin to have those reports moving forward. So apologize that those were not prepared for you now, but our intention was to communicate through EMS advisory and move that forward.
Gotcha. No worries. Appreciate that. I look forward to it
Thank you.
next month. Last 2 points. I didn't see in a report either. I know we've talked about the total number of mutual aid requests to other agencies. Is that a way to get that on the report in the following month as well?
And Mr. Chair, Adam Hines again for the record, that currently is with the EMS advisory report as well. And so we can either do that through that or through the District Board of Health report as you wish.
Appreciate it. And last point, how's it been going with the new implementation of the 30-minute max at the hospitals? I know that was a big hiccup. And how's that been going with the drop-offs?
Let me give you the 50,000 foot view, and then I'll turn it over to Adam and Aaron. From the overall system approach, Chairman, absolutely over the last couple of weeks, we've seen a significant improvement. And obviously, as Dr. Danko presented to all of you, massive personnel challenges across the board in this community right now, as well as across the country, as all of you, I think, are aware. So to be able to bring the health systems together, as well as our fire partners and this organization, and work on different ways to make that transfer of a patient more effective, given the challenges that we have. I have to give my immense gratitude to all the hospitals, because they truly, this is a struggle for them. They don't have the people, and to modify their processes, et cetera, to allow us to go back into service, if you will, was a major step for them. So with that, I'll turn the rest of it over to Aaron and to Adam.
Thank you, Dean and Mr. Chairman. Adam Hines, Executive Director for Remsa Health again. Just to at least share with you the data. So every week, Mr. Abbott, as well as first response partners, meet with the hospitals. As of current, 8% of drop-offs are experiencing offload delay, which as of current, that is 329. Since the 14th of January, which was essentially the day in which we notified the hospitals that we would be doing it. And like Dean said, we're extremely thankful for the effort and work that they have done to try and accomplish this in such a short period of time. There are days in which there have been no offload delays, and the vast majority of them are under the 30-minute mark. We are following up actively with their ED leadership, and they're obviously extremely engaged and working very hard to try and reduce any that are above 30 minutes for whatever reason that may be. So I would just echo what Mr. Dow said, that, I think we're trending in the right direction, and we're hopeful to see that number continue to decrease.
Great.
And I would just add that 8% is down from over 40% in September.
That's great. And just to call out, I see Tiffany Curry. So thank you to St. Mary's and if anyone else is watching the other hospitals too, and your guys' collaboration in order to make that happen. And I know the vice chair and some others on the board were part of those conversations. So I appreciate that. Get our folks back out there. Vice Chair Lucy, I see your hand up.
Yeah, thank you, Chairman. Mr. Abbott or Mr. Hines, can you, just for edification, when we put into effect on the 14th, the emergency protocols, what were the numbers of 911 calls that we were experiencing on those days?
So specifically, Adam Hines, for the record, specifically on the 14th, our system responses were 270. Earlier in the month of January, there was a day in which was a record for the month of January where Remsa was responding to almost 300 calls, 299 responses. But for specifically the 14th, there were 270 responses for EMS in the city.
Okay, and those are down, you say about 40%, or what do you say that those are down now to?
What Mr. Abbott was referring to was, early in September, there was a high percentage of units, near 40%, in which when they dropped off at the hospital would be experiencing a delay greater than 20 minutes.
Understood.
We're now trending to around 8% as of right now. Yeah, so that's the decline.
Great, thank you. That's what I wanted to make sure. Thank you. Appreciate it. Thank you, Chairman.
Thank you. Any further comments, questions for Mr. Dow from the board?
Yeah,
we'll do Councilman and then Dr. Klecken.
Okay, thank you. Just real quick, one of the things, and this is kind of to some of each of our entities to say, we actually even put a video together that we got out to the city of Sparks and went out to the region just telling people what was going on. And just an encouragement. I know Remsa did a great job of we went over and actually they talked a little bit, we did together. But I'm always concerned about someone in an emergency feeling like they're not ahead of time, not understanding what's happening. And so one of the things is just an encouragement to our partners here and anybody else that wants to help get that word out there. Any creative effort we can put towards that only helps people in that moment not be confused, not feel like someone's not helping, and actually just helps them think a little bit differently, maybe about what we're doing with our emergency service. I just actually talked to one of the hospitals today at the EDON thing, and they definitely need this to continue of what we're doing, because they're not at a place where they're like, oh, we're good now. It's not like that. So very important that we keep doing that into our community. We want to make sure we have the safest community possible, but that also means making sure that we leave as many beds open for those who actually really do need the hospital. Thanks.
Thank you for those comments. Dr. Klecken, you're on mute. Dr. Klecken, you're on mute. Oh, you're back on.
There we go. Hear me?
Yep.
Yeah, just had a quick question on some of the report about supervisors being out in the field, and just kind of wanted to see where, in case I missed this, where staffing levels are going at the future. Do you feel comfortable in where you're at and where they'll improve, or up to the level, whatever you need to get to accomplish the goal?
Yeah, so we're facing really two major challenges when it comes to staffing. One is the increased volume. Our community is seeing a massive increase in utilization of 911. It was trending that way before the pandemic. It certainly was exacerbated by the pandemic. And to that effect, we continue to add staff hours, shift lines to our schedule. We've hired at a pace, and we actually have more field providers employed at Remsa than has ever been employed and actually operationalized ever in the past. But the demand continues to grow at an extremely rapid pace. And then the other major challenge that we're facing is with COVID infected providers. Even if the infection, particularly with the Omicron variant, is milder for those who are vaccinated, we have a very good vaccination rate among our staff, but even for those that are experiencing mild symptoms, we can't risk them being in the back of an ambulance or in people's homes providing care and being COVID positive and being a super spreader type of situation. So we do take them off the schedule. At our peak a couple of weeks ago, we had over 30 employees, which is a pretty significant percentage out on COVID. That number is declining, so we're starting to get some of those people back and back into service. So the schedule does continue to improve. I have no nothing, I can't do anything except be positive at this point and continue to look toward the future. But we continue to recruit. January and December are typically our lowest recruiting months. People are typically not going to relocate or go somewhere else due to the holidays. But one of the other major challenges with recruitment now that we're facing, that we've almost never faced in the past, is actually cost of living in the community. So we're actually now starting to get people turning down offers, good offers, for experienced people coming from out of state or other areas due to cost of living. They've actually called us back and said, look, we didn't want to come work for you, but I can't afford to live there. So we are continuing to, starting to face that challenge now as well. But as far as number of providers, we have the most we've ever had on our schedule, the most amount of shift lines we've ever had. We got to keep chipping away at it.
Thank you.
Great. Mr. Dow, then Vice Chair.
Just to add a little bit of color, Dr. Clagging, on the issue of staffing, again, sort of from a 50,000 foot view or a national view. We met with Senator Cortez Masto today. She was on our campus, and that was one of the questions that she asked us, was that obviously nationally, regardless if you're pre-hospital care or hospital care, the last 2 years have been devastating in the individuals in this profession. And as we indicated to her, there is a national crisis. It is getting worse. And that we urged her to go back to Washington, D.C. and look at ways to help all organizations recruit and train individuals, how to go to the folks that are coming out of high school, et cetera, and get them interested in healthcare and different facets of healthcare, because it is a significant problem across this country. Thank you.
Thank you. Vice Chair.
Hey, Chairman. Mr. Dow, can you articulate for me what standards are you guys, is Remsa currently following for your ALS staff and your box staff that are on the front line for quarantine guidelines? Are they following the CDC new 5-day guidelines, or are you still adhering to a longer period of time for those staff members that would be working on the front line with the boxes?
Correct. Chairman Lucy, your co-chair Lucy, we actually hit in the middle. We're holding people for 7 days. And that was decisions made between the clinical arm of this organization, our chief nursing officer, as well as our medical directors. But Aaron, if you'd like, you can add a little bit to that.
Yeah, and I apologize, I don't have the name of it right in front of me. We are following CDC guidelines, but there is a term it's not the 10-day, it's not the 5-day new conventional, excuse me. Thank you very much, Adam. Guidelines from the CDC.
All right, thank you. Appreciate that.
Okay, any further comments, questions? See none. Any public comments? No. Yeah, just accepting. Yeah. Can I have a motion to accept the report for item 8A, please?
I'll move.
A motion, second, all in favor?
Aye. Aye.
Opposed, motion carries. Thank you. Item 8B, Alexia, Remsa, Public Relations.
Good afternoon, Mr. Chairman, members of the board. Alexia Jobson, Director of Public Relations for Remsa Health. For the record, you have for your review the Public Relations report for December, and I have a few things in particular to share with you today. Recently, and in partnership with the Washoe County Health District, Remsa Health donated an AED to the CARES campus, as well as to the Veterans of Foreign Wars Post 10053. Also, new car seat laws went into effect January 1st. Our car seat technician, Nellie Martinez, provided an extensive interview to Colo outlining the changes and what people need to know about how to keep babies and children safe in their seats. In addition, she assisted the Washoe County Sheriff's Office with a Facebook Live demonstration about the changes and how to properly install a seat. Earlier this month, Colo and KTVN covered the need for proper patient navigation, particularly in light of high call volume, staffing shortages, and ER wait times, all due to the high prevalence of COVID-19 in Washoe County. We appreciate the partnership of the media in sharing this important message with the community. Recently, Councilman Dare visited Remsa Health, as you heard, to discuss in a brief video soundbite our efforts around proper patient navigation. This will be included in his update to the Sparks City Council, as well as on social media. And finally, we are in the process of launching our community campaign about our assess and refer protocol. Through paid and earned media and a variety of digital channels, we will work to expand awareness about what people can expect when they call 911 or when an ambulance arrives at their location if they do not have a serious emergency. I'm happy to answer any questions you might have.
Thank you. Any questions? See none, can I get a motion to accept the report?
So moved.
Motion.
Second.
Second. All in favor?
Aye.
Aye.
Any opposed? Motion carries. Thank you, Alexia.
Thank you.
Item 8C, discussion possible proof for the final report of Remsa's health market study. Mr. Abbott.
Thank you, Mr. Chair, and members of the board. Again, for the record, Aaron Abbott, Executive Director for Remsa. As you remember, the purpose of the market study is to ensure that the services provided by Remsa's contractor optimize the quality and experience of care and achieve economic efficiency as described in Article 4.1 of the Remsa franchise agreement. The study was conducted to provide information to assist the Remsa board and the district in comparing market areas to Remsa's franchise area. We retained Fitch & Associates, and we do have them present on the call with a prepared presentation for the board. So at this time, I'd like to introduce Todd Sheridan, a senior consultant for Fitch & Associates, and he can introduce his staff and present you with the final report.
Great, thank you. Welcome, Mr. Sheridan. You're on mute.
Todd, you're on mute.
I didn't get past the first test, the unmute button. All right, hey, Council, thank you all for allowing us to be here today and present. My name's Todd Sheridan from Fitch & Associates, and I'm one of the senior associates with the firm. Been with them for about a decade, and it's been a pleasure working through this project. With me today is going to be Guillermo Fuentes. I'll let him introduce himself for the firm.
Hi, I'm Guillermo Fuentes. I'm a senior partner with the firm, also the chief operating officer. Been involved with DMS since 1988, and it has been a pleasure to work with Remsa over the years.
All right, and with us also Fred Worcester.
Thank you, sir. Fred Worcester, senior consultant with Fitch & Associates. I've been involved in EMS for just about 30 years as well, and it's been a great pleasure being part of this team working with Remsa. Thank you.
All right. I'd like to ask everybody if you can see the presentation we have in front of you. All right. Thank you, Councilman Delgado. All right. So Fitch & Associates, we came and were asked and put together the market study for Remsa based around your 4.1 of your franchise agreement, which is to really look at the quality and experience of care associated with the program and its economic efficiencies. To do that, the goal of this was to look at like and non-like entities. So agencies that are set, such as a public utility model, such as Remsa, that deploy from street corners, also look at non-like entities. Look at entities such as fire department, third service departments throughout the country, and then provide questions, and we'll talk about that in a minute, for an objective survey. During our discussions with Remsa and local leaders, we found and we're having discussions about response times. Fitch & Associates then took a tri-leg approach to looking at this market study. Not only did we evaluate Remsa against like and non-like entities, what we did then was we also looked at their data, understanding where their response time performance, given an objective viewpoint for us to see how they were performing in the community. We then looked at if we were, as Fitch, deploying our resources in their community, how would our deployment in the public utility model, how would that match how Remsa is currently performing today? All in all, we look at it through an objective lens and a subjective lens. And then to do that, we have to verify what we see from our objective moments. We asked Remsa for over 200, to produce over 200 questions and records for us through an information data request so we could verify their responses. The market study itself. The market study itself was, we sent it out to 22 different agencies across the United States and Canada. Yes, we had two agencies from Canada come and participate in the study. Of those agencies, 19 of them responded, and then Remsa would make the 20th agency that responded in total. In our responses, we did invite a local agency, Vegas Fire, who ultimately did not end up responding into the study, but we did ask them to join. Our study, which we'll talk a little bit about more design, was based around 108 questions, looking at benchmark strategies across the country and what we see in EMS systems, and segmented them into 13 specific categories. Overall, with what we sent out to the public, we had 91% participation. We only had one agency that came back with a partial study, which was Cleveland EMS. That's kind of represented in their overall score. They only ended up working through a partially sending in their data. Now, talking about our on-site visit, prior to our arrival, we really asked for a lot of quantitative information. Our firm wants to ground our study in objective moments, in objective data. From that objective data, prior to arriving on site, we did our own data report. We did our own GIS studying. We looked at the entire market study. From that moment, then we came on site, spent time with executive leaders, local stakeholders. We spent time with the 3 fire chiefs and the county manager. Off-site, we then had different, different webinar meetings so that we could get a good sense of what was going on in the community, to ground what we understood from the quantitative moment into what were the objective moments, what people were feeling on site, and really to understand the model and where the model was going. Overall, our initial findings. So from the market study, we looked at, like we said, like and non-like entities as it relates to Remsa. Remsa, in all the responses, scored first in those objective moments. They did very well. They scored 1 point above Lubbock, Texas. One of the more interesting finds, and we spent some time on this, is the cost per unit hour that Remsa puts in the street actually scored roughly the same as they did back in the 2010 study. It was a pretty interesting find, being with the cost of living and how the organization is operating. However, what we will tell you is, in looking at the finances and how things were being reported then to now, is not truly apples to apples. However, it was a very interesting find as it relates to what the cost per unit hour was. We then did that independent data review. We took that upon ourselves to look at, because we were trying to understand what was going on within the community, how COVID was impacting, a little bit about those wall times we just heard about, how overall performance is to their franchise agreement. We did recognize Remsa is challenged with their priority 1 responses. We're going to touch base on that here a little bit later. However, overall, if you look at all the responses, they were above 90% compliant. We then, because Fitch does management services where we go out and actually run organizations, we have our own software where we look at optimizing deployments. So we took all the different priorities, so the Zone A, Zone B responses, and so on, and we said, okay, if we were running the system, would we deploy the same way? Of course, you still have to staff to deploy, you still have to actually operationalize it, but if we were having the same procedures, would we do it the same? And what we looked at is we were very close in certain situations, and in some cases, Remsa actually was better than the model that our computer model produced. So a little more about the market survey. Market survey specifically, again, was 13 different categories. These were very broad categories that we broke down with specific questions. The way it was scored is, if you answered yes, you received a point. If you answered no or did not answer, you'd receive no credit for that score. We evaluated and summed those up to give an overall score. We evaluated each one of the 13 categories, and then we looked at where Remsa was having challenges, and we're going to present some of those to you today. To really look at the entire, everybody we sent this to across the United States and even in Canada, you can see, we got a broad range of folks from a broad, broad areas and broad response types. But what we did do is it was important to us to make sure that there was some comparable to Remsa. So we wanted to make sure the agencies we were looking at in a like or non-like setting had some type of reasonable way that they would deploy, and then we could basically look at them as a similar system. You will see between square mileage, population, system makeup, or type of system, you will see the reasons why we basically picked these agencies and then asked them to join within this study. The overall score, again, as mentioned, Remsa scored first. You can see that we had a wide range after you started getting between the 3rd, 4th, and 5th ranking agency. However, Remsa, they beat the one hospital system, Lubbock, Texas. One of the parts that I want to pause here and really talk about is these agencies as specifically. I mentioned that there was fire department agencies. I mentioned there were third service agencies. We looked at hospital agencies, but we also looked at agencies such as like your Truckee Meadows setup. We asked Pinellas Fire Department to be a part of this because they have a similar system to where they're working in a public utility model where Sunstar is deploying and utilizes the fire service to supplement them. So we wanted to see how that comparison would work and what that would look like from a scoring perspective. So we really were thoughtful in who we picked and the reason why, and to make sure that we had a good understanding of the agencies, the types, and really to benchmark Remsa against. In looking at it from an agency type perspective, we looked at the public utility models, the county-owned or the fire department-based systems, and we averaged all their scores. Of the sample size of what we scored, you will see Remsa still scored first once you averaged all those different types of agencies together, which collectively was evaluated against both the raw score and the mean score for both non-like entities. To break that down even further, really giving a cross-tabular look at both Remsa, non-like agencies, and then the agency type, we want to look at how they scored comparatively as it relates to the type or one of the 13 categories and or different types of response modeling. You'll see highlighted 2 areas where there were 2 challenge points that we look at that we're going to deep dive in a minute and talk a little bit through. However, you can see Remsa overall score was well. As it relates to the accreditation, Remsa here, they're really tied for 5th in overall. So breaking down each one of these 13 categories, Remsa was 5th overall as it relates to how they stacked up in this study. They were tied for 5th. What Remsa was missing the CAS and CPSE accreditations. Now, in what our understanding in speaking with Remsa, that is part of their franchise agreement. However, that was foregone on purpose just with everything going on with COVID. And they're telling us that and they said they had a commitment with the DVOH to make sure they got that completed in 2022. As it relates to the communication center, they have a very sophisticated communication center. We studied and looked across the country on were communication center using GIS to track resources? Were they using protocol-based dispatching? We even started asking about nurse triage lines to make sure we understood how Remsa was performing, even when you're talking about being on the cutting edge of EMS. Remsa was tied for first in this manner. The biggest thing that we found was that there is no direct connection, a CAD-to-CAD integration, meaning from the dispatch software of the city of Reno to Remsa. That was one part that was really the only ding for Remsa in this area. Our understanding was back in 2016, there was an agreement to do this. There has been some functional testing, and there's still a hope for this to go live here shortly, but that's still outstanding from 2016. Some of the challenge point is being able to, that we heard from folks that we interviewed, stakeholders associated with Remsa, that all the data elements from medical first response and Remsa could not truly be evaluated to match data sets to ensure we understand what was fully going on in the system as it relates to a community experience. Overall response time reliability, we looked at how people were doing with response times as it relates to them measuring response times, such as their turnout times, hospital drop times. Were they reporting monthly? Were they reporting annually? Do they report to the FRAC tower? Do they just report averages? Do they use predictive modeling? This isn't looking at how they're performing specifically today. We did that separately. This is looking at, do they do those objective moments that top tier agencies across the country should do? And what we found is Remsa tied for first in this category with 4 other entities. As it relates to production capacity, this is really where we started looking at the makeup of shift deployment, how the resources were being deployed on the street. What we found was we started asking questions on their shift makeup. What was their productivity? Are they measuring how hard they're working the crews? Do they use fixed, or do they use fixed locations such as stations, or are they street corner posted? We did also ask some of the last questions about medical first response. Does medical first response at least use an AED? And are you tracking medical first responders? We also asked, are medical first response going on only high acuity calls, such as those really critical cardiac arrest, cardiac patients, stroke patients, which we identify as Echo and Delta level calls through your priority dispatch system? And what we found was your fire department are going to more calls than just the Echo and Delta. They're going to some of those urgent or non-critical calls. We also noticed that within the EMS, again, there was no CAD to CAD transfer. So being able to have that look at how medical first response is deploying and how Remsa is deploying, and having the data transfer, that was missing in this section of the report. Overall, though, Remsa tied for first, also in this category. As it relates to clinical, Remsa scored the lowest on this, but we realized Remsa is kind of a sophisticated system. So we wanted to really deep dive and understand a little more as to why. Some of the questions that we had in this category were really based around, does your medical director, are they board certified in EMS? Do they have a fellowship in EMS? Or excuse me, let me get that correct. Clinic in emergency medicine and in EMS fellowship. We also want to make sure that they had what's called a health data exchange. So is there an exchange of data from Remsa to the hospitals and then back for Remsa to be able to evaluate the outcomes of patient data? We're seeing that across the country as best practice. So EMS can say, okay, we were dispatched to high priority, but really that wasn't a high priority because the outcomes of these specific call types aren't really deeming us needing to respond lights and sirens and being able to really get a true lens of what's going on. So just because of those 2 moments, that did push them out of the 10 score, that did push them down to 7. However, in our finding, the medical director is highly engaged, may not have those specific qualifications, are highly engaged. And what we found in our study is that they're very proactive as it relates to in the community and having and evolving the clinical care in your community. What we did note, though, is that Nevada has a private not-for-profit community-based health information exchange. It's really a statewide system called Health IE Nevada, and it gives real-time data for anybody within the state. Remsa is one of the 2 EMS agencies that are attached to that system. And within that system, they have done their job in connecting the data. However, the interface is not working specifically, and they hope to have that corrected in 2022. From a patient experience, Remsa scored well with their patient experience. They do patient customer service satisfaction surveys. Not only do they present them to you all as stakeholders, they present them also to their employees to get a better understanding of how they're operating and what the employees can do better. As it relates to safety, Remsa scored and ranked tied for first for safety. They have safety devices within their vehicles. They have safety training programs. They monitor them in real time. They have employee-driven safety committees that they work directly with and have daily interactions. Overall community outreach. I'm going to say I had to take a look at your December 16th board meeting. I thought it was really interesting just to get a kind of an idea of what was going on and what the presentation today would look like. I will say, you know, in what we were looking at and understanding how Remsa goes out and interacts with the public, how they're doing different training of hands-only CPR, stop the bleed, car seat installation, different specialized trainings in schools. This is a standard that should be across the country as it relates to EMS. And even I have to admit the I'll call it, what was it? The It's Okay presentation 2016, talking proactively to the community about when it's right to use an ambulance in such a manner was well put together. This is not seen everywhere. And, you know, Remsa is doing a great job reaching out to the community. As it relates to workforce focus, Remsa scored tied for 7th in this one. Where we noticed in three different moments, that they tied for 7th. One was we asked if everybody was required to have a National Registry certification. In Nevada, you're required to have it from your initial to get your initial paramedic. However, once you have it, you can keep a state level certification. Remsa allows for that to occur where you get your national certification, which most of their employees keep. However, so they do have some employees that do only keep the state certification. Furthermore, what we found is we asked, are your employees above the 50 percentile in salaries? Where we found that they were lower was with their EMT salary was lower than the 50% in the marketplace. Last but not least, this was probably a bad time to ask this question, but it is, you know, this is one of those times we're going through a pandemic. However, they did have an attrition rate of 15%. Overall leadership, Remsa was tied for first in this. And in this one, the only one that they really were challenged with as it relates was, do they have any specific standard or credentialing that they use to promote supervision? So do they have them go take specific courses like the American College of Paramedic Executives? Do they want folks to be bachelor degree? Do they want them to have specific education? Remsa does well with wanting folks and prefer them to have some type of schooling and education. They do not require any type of credentialing like an ACPC cert. But however, across our industry, we're still learning that moment, and Remsa has tied for first in the leadership category. Overall, all operations, Remsa was tied for first again. What we looked at was more largely customer focused, looking at how Remsa was deploying their resources and how they were being innovative. I've heard today, and I heard in other meetings and speaking on site, the ILS program is really getting off the ground. EMS as an industry has a lot of education that's required on the basic, intermediate, and advanced life support program. It would be remiss if we didn't add those into our systems, and we're seeing more and more now people are adopting and allowing these providers who have credentialing, even though to handle those lower acuity calls. That allows for two different moments, not only be operationally efficient, but fiscally responsible. We're seeing that being more and more across the community. Remsa also is one of the first adopters as it relates to the ET3, or Emergency Treatment, Triage, and Transport. They were really the tip of the spear in really getting that off the ground and are continuing that. And we're one of 203 agencies across the United States that is part of the CMS RFQ process that are testing that hopefully future deployment. As it relates to fleet, Remsa scored and tied for first. You'll see most of these are industry standards as it relates to fleet, making sure you meet or exceed from peak a day of 130 to 150% of peak a day vehicles. When you start talking about number of accidents, critical failures, Remsa scored well as making sure that they scored and or were below those industry standards. As it relates to finance, Remsa also was tied for first, or excuse me, ranked first in this region. These questions were really based around: does Remsa collect the subsidy from the community? Do they have a productivity standard that they're trying to meet, and to make sure that they're not overworking or they're trying to manage the workload on their employees? Do they do both a financial and a Medicare audit annually? Do they have a subscription program that's really a fee-based program for folks in the community? And then we start just kind of some qualitative moments where we're looking at, do they have an internal or external billing program? Overall, they scored really well. They do not collect a subsidy. Now, I will say, in your community, you're very fortunate that that's not the case that we're seeing across the country. And what you're seeing right now, we listened heavy on this, is you're really having some urban sprawl that in the future you may want to look at, because you're you're seeing more and more of your community growing out into the rural regions, and that may start to impact overall Remsa's response. And looking at that proactively, we do feel will be good. And one of the proactive moves actually happened in December, was Truckee Meadows Fire Department in partnership with Remsa to really help expand into those regions. And Truckee Meadows Fire Department fire dispatch has already been adopted into Remsa as a whole. I will say at this moment, as we talk about finances and we talk about employees, one of the more interesting moments that we found was Remsa took a strategy and even and left the finances the same as they are today. They took a strategy as it relates to moving staff to all 40-hour shifts, from shifts that were scheduled weekly longer than 40-hour shifts for quality of life, while still leaving them financially where they were. Remsa took this on in the middle of COVID, trying to create some work-life balance and trying to have to hire quite a bit more shifts to make up for those unit hours that still needed to be produced in the middle of COVID. Overall COVID hospital turnaround times, we heard from Remsa, you've heard it publicly, is we looked at those hospital turnaround times to see if across the country, and you saw we looked at across the country and even up in Canada to see what the net impact has been for agencies across the United States and Canada. And as you can see, your turnaround times for hospitals were not unique to just you. This because of the pandemic has been a challenge and something that even Remsa is working through. And fortunate enough in listening to what Mr. Dow stated earlier, it looks like you all have a lot of collaboration. And my understanding was the day before yesterday, you had more than 200 folks with COVID in your hospitals. And those numbers hadn't been seen in quite a while since the height of COVID. So that these patients aren't really critical, but you're busy, and they're still requiring services. Again, when I talked about the productivity, back in the 2010 market study, Remsa reported at $197 per unit hour. So for every unit hour they produced, it was costing Remsa $197 a unit hour. Remsa reported at this time that they were between $160 to $180 a unit hour during this, which was an interesting find for us. Again, it was calculated a little differently in this study locally from Remsa, but we wanted to point out that from a financial and economic perspective, Remsa was moving well with unit hour costing. Again, overall for the market survey, Remsa scored first. They did a phenomenal. They scored well. And as we mentioned, all those different points we just touched on are summarized on this slide. However, Remsa comparative from those objective moments are doing well as it relates to their peers, both from like and non-like entities. Now, looking at the data analysis here, so this is where we took that moment and said, okay, we understand this is a market survey. We understand that's kind of what we were tasked to look at there, but there was a little more undercurrent as it relates to Remsa volumes that we needed to explore just a little more. So we took 5 years of data from 2016 through August 28th of 2021, and we had one of our independent data analysts review their overall service. And we produced a data report that was attached to our overall report that outlines what we've seen within their service. What we found within their service, though, is we looked at their responses over those 5 years, and you can see during 2020, during the pandemic, a drop in overall volume, and then you can see clearly as it relates to 2021 as a percentage, you had a drop right when the pandemic started in 2020 versus 2019 of in April almost 13.7%, and you can see where the volume just picked right back up in 2021 and took off for Remsa and for your communities. Now, what we wanted to understand is where do we think we're going with volume? How are we going to get a better understanding? So what we looked at was a regressive analysis to basically look at what the trends will be, how much volume you will see in your community in the near future. And what we found is that in 2021, you're going to have about a 3.4% if you continue the same rate increase. And that will begin to normalize around 2022, 2023, back to around about a 2% increase, or 2% volume increase. Now we had to look at the compliance, and Zone A compliance is really based around that 8 minutes and 59 seconds. And what we found for the 2021 compliance, we understand that there was some exemptions up until about April 1st within the community because of the state of emergency. However, that was lifted. We looked at it from an objective lens that at a raw compliance level without having exemptions, and then we took the exemptions out for those moments. So the raw compliance of just exactly what the citizens' experience is at 8 minutes and 59 seconds, Remsa was performing at 86.5% to their 90% what their standard is for. When we start looking at their overall raw compliance, they were 89.5% at their raw compliance. So before any exemptions were allowed, if it was some type of delay, if it was some type of weather, for COVID, whatever that reason was. Then once we removed out the 3 categories that they're allowed to remove per their franchise agreement, that got them to an overall compliance of 90.3%. From our data summary, as we mentioned, overall 90%, their raw compliance was actually 86.5%, and we wanted to give credence to what people were saying there. Overall responses were higher in 2021, but we're looking to see those normalizing here, hopefully in the future, if everything continues to trend the way the analysis looked. However, what we did find is because of some of the policy changes internal at Remsa, with folks staying at the hospital, they were dispatching folks at the hospital and trying to clear them in a certain time period to get them to go out to a call. From a functional perspective, what that means is that unit was at the hospital dropping off a patient and or getting ready to clear, and they were able to stack a call and get them because they were going to turn around in the next few moments because there may not have been a unit available or not a unit closer. So what they've done is that increased time for turnout time at that moment increased from 2019 by about 3 minutes. And this could be for a multitude of factors. If it was something to do with turnaround at the hospital, if it was wall times, it was staffing, whatever that could be, that was a policy change there internally. Again, looking at, and then the third leg of this is really looking at the deployment model. Again, Fitch has our own software, how we look to deploy our systems. We wanted to see how we would deploy if we were in Remsa applying it to the current contract as it is. Again, it's not looking at staffing. This is not looking at policy on how it's deployed. Is their deployment plan would match our deployment plan. We first looked both at a heat map and what we consider a commensurate risk mapping. So everybody's typical used to heat mapping. You can see a bulk of the responses happen within both City of Reno and the Sparks area. However, we use a commensurate risk mapping that is a 1 kilometer by 1 kilometer commensurate risk that is really about what looks at it from an urbanized area. And we determine that urbanized area by saying if there were 4 calls that happened within a month with 50% of their adjacent sides of that 1 kilometer by 1 kilometer area, then we deem that more of an urbanized response. In the green areas, we look at that as there were 2 calls per month, or excuse me, 2 calls per quarter with 50% of the adjacent sides. And if that were to happen, really you would have, we consider that rural area. And anywhere that does not have it, we'd consider wilderness. This gives us an understanding of a level of risk when we're designing a system. So when you're modeling out what your model should be, we really look at it from a risk base and what's the risk tolerance within the community. So just from a presentation perspective, and you'll see where we looked within our report, we went through all the zones that Remsa is responsible to. In zone A here, we looked at on the left-hand side, the Remsa's current deployment and their posting plan today. And in their posting plan today, they provided us the exact post that they deploy from, and then we ranked them on how they were doing against our modeling. And what we found, and with this, let me back it up, we use what's called a marginal utility approach. So what's the value add of each resource in the community? Or in this case, what's the value add of each post that is being used? When we look at that value add for a post ranking number 1, where they post at, they can capture 81% of the historical volume within that one post. When you go to the second post, it adds about a little over 7% value, and so they can meet at 88% from 2 posts. However, they can capture for Zone A calls 859 from 3 posts, 92% of the historical volume. That matches very closely to the Fitch model, as you'll see on the right, as when you add to ranking post 3, you will see where we both came to 92% in overall response modeling or deployment modeling. So our findings was that their deployment and Fitch's deployment really match exactly what each other would be doing if we were deploying it independently of Remsa. So in final summary, we believe that that Remsa scored very well against like and non-like entities. Overall scored first. They had a couple points that we pointed out that they could do better, or they have in the works that they're looking to accomplish in 2022. Their cost per unit hour, we thought was an interesting moment. We can't, again, there was a little bit difference in calculations. However, we found from a value perspective that was an interesting find. Overall, from the data and deployment, they were challenged in their priority 1, however, was overall 90%. I will say that, in what we're seeing from our trying times, we are going through a pandemic, but Remsa is really working with their community partners. It sounds like, and they're really stepping up on both the staffing side, making sure that they're trying to figure out a work-life balance, irrespective of what we're going on within the community. And last but not least, from a deployment, we see that if we were deploying the system, it would be very similar to, if not almost the same as what Remsa is doing today. So in final summary, we feel there's no evidence to support the need to place the ground ambulance contract out to competitive bid. We feel Remsa is really proactive in your community. You're going through some trying times, but what we do see is that, as you're going through some of these trying times, as just an overall community, you're having a lot of growth. Your model is evolving. Your level of risk is changing in your community. And, it's clear that, council has an opportunity to really look at the model, evaluate it, see if today, if it's working, which it appears to be working, struggling through some of the times that we've talked about with priority one. However, it's a very sophisticated model, but we didn't evaluate to know if this is going to be sustainable in 20 years. But today, we feel it's doing well for the community. So with that, I will take any questions.
Thank you. Very in-depth, detailed analysis. Thank you for the summary. If you could take down the.
Yes, sir.
Yeah, thank you. I can see everybody on the board. Any go to the board for any questions for Todd and his team. Look around. In summary, congratulations, Remsa. It looks like you have scored tremendously well across the nation with those respected comparisons. I know we're lucky to have all of you guys supporting our region, and of course, not to move away from all the number ones that you guys did. Dean, you guys showing off, but kind of diving into some of the other pieces that you highlighted, Todd. You highlighted, or maybe, and Dean, I know you guys have talked about this, and I believe Aaron had spoke to this also with respect to recruitment, EMTs not hitting the 50th percentile. Of course, that's going to just increase overall cost. Do we have general thoughts or ideas on how we can get there? Aaron, I see your hand up.
Thank you, Mr. Chair. I actually wanted to comment on just one thing that was presented and just make a quick correction.
Yeah.
The CAS accreditation is actually not required in the Remsa franchise agreement. The dispatch accreditation is, and so dispatch accreditation is something that we retain and maintain. So just wanted to make that quick comment.
Cool.
Thank you.
Thank you, Aaron.
Aaron, did you want to speak on the 50th percentile, or Dean, with respect to the most pulled on the report?
Yes, the percentile is correct. And as an organization, up until about 2 years ago, we had a very small, if you will, workforce of EMTs compared to advanced EMTs and paramedics. So as we've been bringing more and more of them into the system and functioning in the system, yes, there needs to be a better, I think, effort at improving them and moving them up the scale. Likewise, I think all the individuals in this organization need to be moved up the scale. So right now, and over the last, Chairman, about the last 3 months, our HR department has been going through a national survey with other organizations and like organizations and other, even hospital systems, in trying to measure where that is. And we're hoping that sometime mid-February or so, we're actually going to get the results of that study and be able to sit down and analyze it. But the organization was able about 7 months ago to give every individual in the organization, that's inclusive of all the folks that work behind the scenes, if you will, to make sure that we're able to do what we do every day, 3.5% increase. And our goal is to continue that. But as you well know, that's in this industry, that's a very delicate balance between that and reimbursement. So.
Thank you. Looking to the board, questions for Todd or his team. It was interesting to highlight it. Oh, Councilman, go ahead.
Yeah, I just wanted to say, I mean, what a report. It's nice to see. I mean, a lot of times we're comparing ourselves against ourselves and we wonder, have all kinds of questions. We obviously know where we need to grow and as a community, but good job. I mean, it's neat seeing that. One of the things that I'm glad you hit on, I always have questions on when it comes to our timing and watching on our region, we watch those timings and how quick someone can get there. It was nice that you even for us minus the exceptions, so we can kind of see how we're doing. Yeah, do we exception our way out of this last region? You know, so it was kind of a nice, because one of the questions I had going into this is how much do we allow exceptions to give us a good report? But you even laid out that even with that, that gives us a good thing. And I think as a region, we have a lot of obvious continued collaboration and work to do, but I really appreciated hearing through a lot of that information. I don't know that I have a particular question. I just think it's a very good exercise and gives us a little bit of a litmus test to kind of look at and see where we're doing compared to others. So thank you.
Thank you.
Councilman Dare, if you don't mind me saying, we appreciate that. This is not something that a lot of entities do across the country, really comparing themselves like you all do, and then continuing to strive. So, Councilman Dare, to your point, it's a great exercise. Models are changing across the country. Challenges specifically as it relates to each community are unique, and your community has their own, but y'all are taking a proactive approach, continue to measure yourself. So I applaud you for that.
One question I have, and you mentioned, we obviously know our urban sprawl and our growth and what we're doing. And that's something, definitely each of our cities, we're almost in the state of Nevada, we're set up where we have to grow, just taxes, everything. You have to grow just to stay sustainable. But then in the growth you're doing, you also become unsustainable in other ways. And so it's a hard combination. I don't know. We definitely are trying to find creative ways to answer that. And I don't know, in your studies, I wonder if there was anything that we found, or if anything was found in other people in that same situation.
Sir, Councilman Dare, I will say that, this was really on the market study side of things. We didn't really look at the model as it pertains. We've done that in other communities, really taking a deep dive into the model, what's working good, forecasting into the future. This is really set around the market study, and then we really started to expand off of things we heard from local leaders to really get more of a better litmus test of what was going on in your community. Your community is unique. I was understanding from Aaron and Dean, really understanding your population growth, what's happened here recently, some of your traffic patterns, what's really going on in Reno. And it became very interesting to me that how much your county was expanding and growing. So to your point, that proactive look at it, I know Dean and I had some conversations really about what does the future look like? How does that, really play in for Remsa here, especially with the population growth and really the expansion that's happening within your community?
I did have one question because it came up today in conversation, and maybe you hit on it. There was just a lot of information, so I apologize if you already said it. Was there any studies on in what you said with transport from hospitals to get them out? Because that's one of our problems we're having, is that we don't have enough bandwidth to get people out of the hospitals and get them out of there. So, when it comes to ambulance drivers and things of that fashion, is there any studies that have to do with that portion of the work that they do, of just helping the final, getting our patients out of the hospital to the next set, so we have room in the hospitals? Does that make sense, my question? Transport.
Councilman Dare, you did break up on my end. If you don't mind, I'll just repeat what I thought I heard.
Okay.
You were talking about, are there any studies as it relates to and or seeing about how the people are staffing to help get patients out of the hospital to free the hospital up? Was that your question, sir?
Yeah, just the transport piece of what Remsa does for our community. Was that in there? I don't know that I heard that in your conversation.
Absolutely. No, we specifically looked at it as it related to the deployment for the 911 side. And really what we were doing was benchmarking to understand from a community experience as it relates to 911 service, and that's really the lens we looked at it through as it relates to the market study and deployment. We didn't look at there's real staffing to demand. We didn't break down into each community specifically as it relates to the current model, what you see into the future, hospital discharging, times of discharge. That wasn't part of this study. However, that is a point to look at, especially when you really look at system design components.
Thank you. Thank you very much. Appreciate you guys.
Thank you, Councilman.
Any further questions? To simplify it in a very simplified way, looks like what the questions that were asked of Remsa in terms of its current state is that you guys are doing a great job, Dean. You should be proud of your team. And again, we appreciate all the work you're doing for our region. You guys opened up the doors and let some third party in, which we always appreciate in terms of the audits and taking a look. So congratulations to you and your team. We thank you very much. I don't know if you have any comments on that.
I just immensely, as all of you know, I've been involved in healthcare for 47 years, and this is a very unique community overall. It's a very unique organization, and just massively proud of the roughly 500 full-time and part-time employees of this organization, because they make this place tick, and they're absolutely dedicated to the community. So thank you.
So congratulations, team. Congratulations. Some questions I think that were highlighted that maybe it's an opportunity for strategic planning in the future is, of course, to what Councilman Dare spoke to is, and what Todd, his team kind of brought out a little bit is opportunities, maybe not today, but in the future, to talk about how do we deal with the ever-changing climate and the growing population that we have upon us to build a stronger system and support for Remsa in our region. So I think that may be another conversation to have on another day. Thank you, Todd, to your team. Is there any public comment associated with this, Susie? Again, looking to everyone for any further comments or questions for Todd and his team. Seeing none, thank you very much. I'll look for an action move. Can I get a motion, please?
A motion to accept.
Thank you, Todd. I got a motion.
Hey, excuse me, Chair Delgado.
Yes.
This is the market study is required by the Remsa franchise agreement with the District Board of Health. And so this report is important to make a determination that because the report is the basis for the board to decide whether or not Remsa is required to go out for a competitive bid for the provision of ambulance services. So if we could have a motion that not only accepts the report, but also includes that determination that no competitive bid for the provision of ground ambulance services is required at this time. That's an important part of the board's oversight for Remsa and the implementation of that franchise agreement. Thank you.
This is Dania Reed, Deputy District Attorney. There is language in the agenda item that would lend itself to a motion if somebody would like to put that on the record.
Okay, I'll find it if you would like. Is it just at the beginning?
I could read it for you if you'd like to.
Yeah, do
like
that, and then I'll say
assistance?
what he said.
There you go.
So I would propose that the motion would be moved to accept final report for Remsa's health market comparison, performance, and deployment study with a possible determination, with a determination, excuse me, that the market study reveals that the performance of Remsa Health's contractor is reasonably competitive on service and cost, adjusted to account for relevant differences in market characteristics, and that no competitive bid for the provision of ground ambulance services is required at this time.
I agree with that. That's my motion. Thank you.
I have a motion. Is there a second? Can I get a second from a board member?
Second.
A second from the vice chair. Further discussion? Seeing none. All in favor?
Aye.
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 Any opposed? Motion carries unanimously. Congratulations. Look forward to continuing to work with you, Dean. We'll talk about the long-term sustainable plan in the future. Moving on to item number 9. Thanks, Fred. Review and discussion of possible adoption of business impact fee. Mr. Vega.
Yes, thank you, Chair Delgado, members of the board. For the record, Francisco Vega, Director of the Air Quality Management Division. I do have a presentation, and then I can open it up for question and comment. So let's see. Can hopefully everybody see the presentation?
Nope.
Nope, not yet. How about now?
It's coming. There it is.
Okay, perfect. And please feel free to jump in anytime if you guys have any questions. So just kind of a quick overlay of what we're going to be discussing, a little bit of history of the regulation, some steps we took to engage in stakeholder and public engagement, the purpose of this revision, some next steps, and then again, questions and comments. So history of the regulation. Wood burning device regulations have been in place since the late 1980s. The regulation really was put in place to address issues associated with wintertime pollution, and particularly from particulate matter and carbon monoxide here in the Truckee Meadows. Just a kind of a little side note, emissions from wood burning devices account for up to half the wintertime pollution. As a result of the regulation, the Truckee Meadows was able to come back into compliance with the EPA standards. And again, just kind of an update, a couple of years ago, the EPA strengthened the emission limits for wood burning devices. And I've got some kind of data to share with you guys on just the success of the program. So since 2006, approximately 1,300 wood burning devices have been replaced with cleaner burning devices, and approximately 1,600 devices have been removed. And then based on a recent survey, it is estimated that approximately 27,000 wood burning devices are still in operation in Washoe County. So kind of just to put some of that in perspective. So stakeholder and public engagement, I'll say that this has been a long process. Even prior to the stakeholder workshops, we started talking and reviewing the regulation back in August of 2020. So this revision that we have been sharing with you here today has been a long time coming. Again, we did a lot of really self-evaluating and just seeing if we can improve on our customer service associated with the regulation. But the stakeholder workshops, so we did 3 stakeholder workshops that were held in early November. The stakeholder workshops are really targeted to specific stakeholders, specifically wood burning device dealers, inspectors, box stores, city and county building officials, real estate agents, and title companies. And I like to mention that those were noticed with a press release. We did social media posts, and also sent the notices out to anybody who had subscribed to our air quality email list. So again, we tried to do a really good job of trying to make sure that the information was out there. In addition to the stakeholder workshops, a public workshop was held on December 14th. And then comments could be submitted in person during the public workshop, and also by email up through December 17th, 2021. And all public comments that we received have been addressed, and responses have been included in your board packet. So the purpose of the revision, I already talked about how the regulation has been a success, but we really wanted to do some self-evaluating as far as, is there room for improvement? So after that review, we really felt like there was area for improvement, and especially our ability to add clarity, transparency, and consistency associated with the implementation of the program. We wanted to revise language to remove ambiguity and clarify the intent of the regulation, reorganize for easier reference, and then to add compliance flexibility and clarify requirements for device exemptions in order to address any inconsistencies that may have been in place. Lastly, we clarified existing and added additional definitions to, again, just really make sure we're being clear and add transparency. I think it's important at this point to point out that the revision does not change who is affected by the regulation. As is currently written in the regulation and as proposed, the regulation applies to escrow transactions in which property is changing ownership. So just wanted to point that out. So here's a table kind of laying out the compliance flexibility that we're talking about. Again, the standard that we're trying to meet is making sure wood burning devices meet that May 15, 2020 emission limitations. In the current regulation, there's really only 2 compliance options. Either it meets that 2020 standard, or it has to be replaced with a, let me back up. If it does not meet that 2020 standard, it has to either be removed or be replaced by a device that does meet that 2020 standard. So again, as currently written in the regulation, that's your really only two options. As proposed, we're trying to introduce 3 additional compliance options. In addition to having it replaced with a device that meets the 2020 standard or removing it, we're also adding the ability to render the device inoperable. So as opposed to removing it, you can just render it inoperable. In addition to that, if you can prove that the device met the standard when it was installed, it can stay. Some background on that, again, we got a lot of feedback from stakeholders that said, well, I installed my device in 2018, and now because I'm selling my home, I have to either remove it or replace it because it doesn't meet standard from 2020. And again, it was really only saving grams for the device. Again, so we took a look at that, took that feedback, and really wanted to introduce this compliance option. Lastly, if you can prove that the removal of the wood burning device would cause damage, we're willing to provide a one-time exemption from that removal requirement. It would still have to be removed at a subsequent escrow transaction, but again, to allow you to navigate the current escrow transaction, again, that seems to make sense. So again, hopefully this points out to the increase in compliance options for this. I also would like to add that it's clear that the approval of these exemptions is established in a regulation. It is not a subjective decision made by air quality staff. That's again one of the things that we wanted to make sure is clear is that the requirements to meet these exemptions is in the regulation, and again, to remove any kind of inconsistencies that there may have been in the past. Next steps. Today we're doing the business impact statement. If that is approved by the board, we will have the public hearing at next month's Board of Health meeting. And then in between now and also the effective date of the rule, which is as written right now is July 1st, we will do furthermore stakeholder workshops just to make sure it's clear what the expectations are. With that, I'd be happy to entertain any comments or questions. And let me stop sharing, hopefully. Oh, there we go. Thank you.
Thank you, Mr. Vega. Any questions for Francisco?
I just have a comment. I just want to say I got to speak with Francisco quite a bit about this particular thing, and it's something that has been an ongoing work for them to try to come up with some of these answers. I actually really appreciate that we found some balances in here that give people some time to get things right. It's good communication, and it seems like we have a chance to really educate and walk with people. I think it's a great approach, one that we don't always see in government, that we give a little bit some options. So I like that. Thank you.
Thanks, Councilman. Any other comments from the board for Francisco? Seeing none. Any public comments, Susie, on this item? So we'd be looking to support the can I get a motion for Francisco to move forward with taking and moving forward?
Move to approve.
Motion and a
second for Brown.
And a second. Further discussion.
Just one question, Danny. I know there's that requirement to set the schedule for the public hearing. Is
right.
That something that we have to state?
Yes, thank you. I was planning to point that out. You do need to specifically set the public hearing for, I believe it's anticipated February 24th, 2022 at 1 o'clock.
February 24th, 2022 at
1 o'clock.
Okay. The motion, so we'll set the public hearing for February 24th, 2022 at 1 p.m. regarding the impact statement for the wood burning devices.
You need that as part of my movement because it's so moved. I don't see that in. I'm reading through your packet. I don't see that's in here, but I definitely can say that.
Right.
So
So,
agreed.
Sorry, Dana Reed again. So what you would do is your motion would be to approve the impact statement, and then subsequently chair can set the hearing for February 24th, 2022 at 1 p.m. So the motion.
I found your motion. I'll just read it. I just found
Thank
it. Move to approve and adopt the business impact statement for the proposed revisions to the District Board of Health regulations governing air quality management, section 040.051, wood burning devices. Further move, further move to set a public hearing for possible adoption of the District Board of Health regulations governing air quality management, section 040.051, wood burning devices, for February 24th, 2022 at 1 p.m. Thank you.
Beautiful. Thank you, Councilman. I have a motion.
Second.
By Brown. No discussion. See none. All in favor?
Aye.
Any opposed? Motion carries. Thank you, Mr. Vega. Moving on to item 10, staff reports and program updates. 10A. Francisco, you're back on.
Yes, sir. Thank you, Chair Delgado, members of the board. For the record, Francisco Vega, Director of the Air Quality Management Division. I don't have anything to add to my report, but I'd be more than happy to answer any questions.
Any questions for Mr. Vega from the board? See none. Motion to accept your report. All right. We'll move on.
You need a motion, or if we didn't change anything, isn't just stay the same?
Yeah, we don't have to take a motion.
Okay.
Thank you, Francisco.
Thank you, Chair.
Item 10B, Lisa Lottritz, Community and Clinical Health Services. You're on mute, Lisa.
I hit it one too many times. Sorry. Good afternoon, Lisa Lottritz, Division Director for Community and Clinical Health Services. I just wanted to bring to attention Dr. Clacking and Commissioner Dare the information included in our report about, you had questions last month about the increase in sexually transmitted diseases, and staff, they were on the meeting and they wish they could have chimed in with me. So they had a good point that in 2020, a lot of people were not out being tested, and so we have seen an increase, and that is one big reason is more people are out being tested. So just wanted to bring that to your attention. And then one other addition, CCHS is implementing the Zero Suicide Program. And we have 13 staff members who volunteer to participate in the implementation leadership team. And they will start a training series on this coming Monday, January 31st. So we're looking forward to getting that implemented in our division. That's all I have, but I'm happy to answer any questions.
Any further questions? Lisa, no? Thank you for the report, Lisa. Appreciate it. Dr. Clacking, go ahead.
Yeah, just had a quick one. How long is that training session for, or how long does it take for them to get through that?
As our injury prevention team member said, this is a marathon. And so the training is actually seven trainings. And that's just the very beginning of this implementation process for us. So first they go through the training, and then they will come back and start how we implement this in our division. But I think it goes through June is what the last one.
Thank you.
Further comments from the board? See none. We'll move on to, thank you, Lisa. Appreciate it. We'll move on to item 10C, Ms. Erin Dixon, Environmental Health Services.
Good afternoon. For the record, Erin Dixon with Environmental Health Services. As you can see from the report, instead of highlighting one program, I'd really like to do a brief year in review of kind of the impacts that Environmental Health Services have experienced. It was calendar year 2021 was definitely full of unexpected challenges. First of all, with staffing. For the entire calendar year, James English was assigned as the Regional Operations Chief Health Branch Director for the COVID response. While we are very excited to have him back in Environmental Health Services, we know he had a great impact there, but we did miss him quite a bit. We also had 3 staff that continued to complete inspections of the 17 resort facilities in our jurisdiction. The COVID restrictions, as they were adapting, really impacted a lot of our permitted facilities. For example, with when the COVID restrictions were lifted for spas, or as many people know them as hot tubs in mid-spring, that led to a wave of requested openings. We have approximately 176 permitted spas in our region, and staff were able to meet the needs of and open those inspections very quickly. As many people were aware, special events were allowed to return to our community in the spring under very specific state guidelines. Staff developed a process for reviewing, submitting plans, worked closely with the state and regional partners to ensure consistent guidance was being provided to all event promoters. And as the COVID-19 restrictions were lifted, the review process was adapted and then disbanded, and the special events returned fully to our community with over 700 special events permit issued. In addition, many of our permanent facilities had to adapt during and after COVID-19 restrictions were lifted. Many changed their operating hours, adjusted their services or their menu, and they often struggled to keep experienced staff. This led to increased re-inspections for many facilities, with the largest impact on the food facilities. Staff continued to provide education and guidance to operators while ensuring that food safety was not being compromised. But in addition to the challenges, there are also several great successes. The food program applied for and was awarded the 2021 Samuel J. Crumbine Consumer Protection Award. We had 2 programs update their regulations, which is a huge lift. We had 5 retirements, which led to increased hiring and a level of training that was slightly unprecedented, but our staff continues to provide exceptional, very structured training for the new team members. Staff maintained a 100% first-time pass rate for the Registered Environmental Health Specialist exam, and we had 3 staff pass that exam this year. The Safe Drinking Water Act program was reinstated. The underground storage tank program was redesigned and reinstated. The Vector program created a live interface that allowed the public to actively see where, when, and the amount of product being utilized to treat mosquito breeding. And then finally, staff responded to over 4,700 public records requests, which is pretty impressive for our front office staff. So overall, 2021 provided multiple opportunities for the EHS team to be creative, adaptive, and respond to new challenges, but they embraced this opportunities, and they were able to make improvements that really directly impacted and improved public health in Washoe County. And I really am honored to be able to stand here and go over these wonderful achievements with you and represent environmental health. So that is it, and I'm able to answer any questions.
Thank you, Aaron. Appreciate that. Vice Chair.
Thank you, Chairman. Ms. Dixon.
Yes.
Does the child care facility inspections fall underneath the Environmental Health Services Department?
Yes, so that's actually a collaboration with HSA. And so while we do part of the inspections, they actually issue the permit and do the other half of the inspections.
Correct. But you, from the health district side, it does fall within the environmental health district, correct?
Yes, under a health district, environmental health.
I mean, environmental health services. Thank you. Ms. Dixon, now in regards to regulations and requirements for quarantining for children and staff within the daycare and healthcare system, daycare and childcare system, are those requirements set by your department? I know the CDC requirements changed, and Washoe County has not adhered to those new changes via CDC for those child care facilities. Is that a dictation by your direction, or is that from the health district officer, Ms. Dixon?
So my understanding that it actually does not come from environmental health. My understanding is we follow the directions provided by the CDC. Okay. But I don't know if Kevin or Ms. Nancy would like to jump in here and answer that.
Yeah, Mr. Health District Officer, because I've had that question a couple of times from some of the child care facilities within Washoe County about where that guidance would come from, because they're confused whether or not it comes from you, the CDC, and how they should be responding to that.
Yeah, and that's an excellent question, Vice Chair Lucy. the CDC changed their guidance for K through 12 and reduced the isolation period in quarantine for those facilities, but they have not changed the guidance for the childcare facilities. So the state it takes the CDC guidance and supports that with a technical bulletin for the state, but they haven't issued any changes for childcare because CDC hasn't changed their requirements for the childcare facilities at this time.
Okay. All right. Thank you, sir. Just thank you for the clarification.
Certainly.
Thank you, Dixon. Thank you, Chairman.
Thanks for the question, Vice Chair. I know I received questions from other child care facilities. And just for general clarity and information, District Health Officer, who would we advise those owners of the child cares if they would like to, for reconsideration or other things? Would that go to the state versus us, since we take direction from the state regarding child care?
Yeah, I would direct them to the state's program. They're the ones that provide us with the technical bulletins on changes for the state's approach on that.
Okay. Thank you. Any further questions for Ms. Dixon? See none. Thank you for that report, Aaron. We'll go to item number 10D. Dr. Dow, Nancy.
Hi, good afternoon,
Hey.
Mr. Chairman, members of the board. This is Nancy Dow, Division Director of Epidemiology and Public Health Preparedness. So you have my report. I don't have anything in particular to add. The first month of the year 2022 has been a very busy month in the EPHP division because of the unprecedented new surge of COVID cases. Staff in public health preparedness worked really hard to make accommodations to testing, and those in the epidemiology program upped case investigation and contact tracing capabilities through various channels and adjustments. I do want to note on the side, away from COVID, that our RSV total this season up until the end of December 2021 has already reached 956 cases reported. So discounting the 2020 to 2021 season, which by the way had only 5 RSV cases in Washington County reported, the current season numbers up until now already surpassed the entire 2019 to 2020 season total as well. This season's RSV started much earlier. Uptick was noticed since June. So always keep in mind of other respiratory diseases currently circulating is still important, especially for younger children. That's all from me. I'm happy to answer any questions you may have. Thanks.
Great, thank you. Any questions? See none. Thank you, Dr. Dow. Appreciate it. The last report we have is a 10E District Health Officer.
Yes, thank you, Chair Delgado. As Ms. Dixon mentioned, Mr. English has stepped down from his role as our operations chief for our COVID-19 response, and Gail Erickson is now in that role. I know the board wants to recognize Mr. English for his extraordinary service during the response, but I wanted to hold off on that until we're in better conditions with COVID-19 and we could be meeting back in person for that. I do want to also just say we're excited to be moving forward with the community health needs assessment. And we have a committee engaged of representatives from a number of community organizations that are working with us on that. So that's something we had deferred as we were consumed with our response activities, and are working to get that completed this year and move into the community health improvement plan so we can have that work completed for the next strategic planning effort by the Board of Health. And also we have a committee that's a staff committee developing an employee recognition program. They're just about completed with that. We're looking for suggestions from staff for the name on that program, and we'll be providing you a presentation on that. I think it'll be a nice program that recognizes staff service around the values of the health district. So that's my report. I'm happy to take any questions.
Thank you. Any questions for Mr. Kevin Dick here? All right, see none. Thank you. We'll close item 10E, move on to item 11, board comments. Any comments from the board?
Yes, I have one. Hello?
Yeah, go for it.
Thank you. I wanted to see if we could get an evaluation or some kind of report regionally on mental health. I've been hearing I know we've had some people close, some rumors are closing, some rumors of future closing. I'm a little concerned, a little bit what I've heard, but part of it is I'm probably naive to all that's happening, and I don't want to be. So if we could try to have something come back that could give us a little bit of a snapshot of what's happening, who's involved, the players, would be really great. And I just want to say to Julie Ratty, congratulations. I know we kind of speed bumped her award, and I think that's amazing when people are recognized and for what they do. So anyway, thank you so much.
Great comments. Thank you. Any other comments from the board? Yes, Susie. Okay, thank you. Again, one more go around to the board. Any comments regarding board comment item 11? Okay, seeing none, we'll close item 11, go to adjournment. Can I get a motion?
Motion to adjourn by Brown.
Motion, second from thumbs up from the councilman there. All in favor?
Second. Aye.
Aye. Aye.
Thanks, you guys. Appreciate it. Stay safe.
Thank you.
Thank you, team.